Good afternoon, everyone. I think we better begin. There might be a few people that will be filtering in, but we should begin now. My name is Greg Marchildon. I'm the site director for the Western Regional Training Center, Health Services Research here at the University of Regina. And it's my great honor to be able to introduce Professor Antonia Maioni from McGill University. Now, Antonia is currently Professor of Political Science and Professor in the Faculty of Medicine at the Institute of Health and Social Policy at McGill University. She's also a member of what is called the International Masters for Health Leadership Program, which is one of these extremely expensive executive programs, in the McGill Faculty of Management. And some of you may know her because she is currently the president for the Federation for the Humanities and Social Sciences. And she came to the University of Regina to speak, about a year ago? That's right. She is on the board for the Canadian Foundation for Health Innovation. And from 2001 to 2011, she was the director of the McGill Institute for the Study Canada. She got her BA at Laval, her MA at Carleton's Norman Paterson School of International Affairs, and her PhD in political science from Northwestern University. The thesis that she did at the time was eventually published as a book by Princeton University Press, actually in 1998, and it's a book that many of you have probably read. It's called Parting at the Crossroads, The Emergence of Health Insurance in the United States and Canada. In terms of her teaching, she does a graduate seminar in public policy, and I think she often wishes that there was a public policy school at McGill. So you just have to move here. She also teaches an upper undergraduate course in healthcare in Canada and does modules in health policy for the medical students in the Faculty of Medicine at McGill. They created a new curriculum. Health policy is now a part of it. Unlike the College of Medicine at the University of Saskatchewan, in which they have an elective course on health policy, and that took 4 years to get off the ground. In terms of outreach, many of you have seen her on television. She's been a political analyst for CTV News since 2008. She's a regular contributor to the Globe and Mail, and in fact, yesterday there was a major piece by Antonia called How Marois' Laser-Guided Focus on Identity Tilted the PQ Toward Majority. I went on last night to take a quick look at it. Just had gone on, and there were already 241 comments. Now, you're interested in her research, and she mainly does work in health policy. And in fact, when the Romano Commission was operating, we asked Antonia to provide a major piece of work on roles and responsibilities in healthcare policy, and really mean federal provincial roles and responsibilities in healthcare. And since then, she's done a lot of work on the role of the courts and the impact of major judicial decisions, particularly those out of the Supreme Court, on healthcare. And of course, she's continues her work on health reform in the United States, comparing that to Canada. And finally, Quebec politics and health reform, which is what she's going to talk about today. The title of her presentation is Plus ça change, plus c'est la même chose, Healthcare Policy in Quebec. I just want to say, Antonia, bienvenue, and if I can say this properly, benvenuto. All right.
Thanks so much for that very nice introduction, and I'm so glad I'm finally here. We had bit of a scheduling conflict before Christmas, and I so absolutely wanted to make this trip to Regina for several reasons, and the most important was I wanted to be able to engage with you all on this paper, which has to do with where health care policy comes from in Quebec and where, in fact, it's going. And I know Quebec may seem very far away, but as I was telling Greg, the one thing we do have in common with you is winter. Sometimes we feel in Quebec that the rest of Canada doesn't really understand winter, or maybe we're talking about Toronto, but certainly when you arrive in Regina, you know that we have this very much in common. So let me begin by just speaking of Quebec. So this is Quebec in winter. This is our National Assembly, and Greg's promised me a tour of the Legislative Assembly here in Regina, but our National Assembly, which is known as the wedding cake by some people because of its rather interesting architecture, is in effect the seat of government for Quebec. As I'm going to try to make it clear, though, in this presentation, it's a lot more than that for many Quebecers. It really is the primary focus of their interest in terms of where Quebecers feel that decisions are being made about their future. And you can tell by this kind of special future, we have our own, I don't know if you call them logos now or whatever, but our emblem, which is based on a lot of emblems that you see across Canada, but ours also involves the word Je me souviens, which is a direct link to Quebec's past, which for many people is quite different than that of the rest of Canada. Okay, so speaking of that past, just very briefly, I'm not sure how many people are up to speed on Quebec, so just, the kind of Quebec Politics 101 in one slide, is that Quebec was one of the original signatories of the British North America Act that created Canada. It's now, it still is Canada's largest province by size, the second largest by population to Ontario. And the other thing that makes Quebec very distinctive and has a huge impact on not only internal politics in Quebec, but the relationship with the rest of Canada, is that Quebec is Canada's only official French language province, and 80% of the Quebec population is Francophone. So French is the dominant language in the province, in particular outside the city of Montreal. The main political issues in Quebec may be different than the main political issues in Saskatchewan or in other places in Canada. In effect, one that I think is important everywhere is the economic question about the role of the state. So this kind of what is the role of the state vis-a-vis the private sector in economic and social development. But in the Quebec case, this has meant kind of a distinctive or a distinct structure in terms of how the state operates, a distinct legal system, different kinds of political parties than you see in the rest of Canada, in some ways different political institutions, different social movements certainly, and the relationship between social movements and the state, and of course the language, which into the identity politics that Greg mentioned I wrote about yesterday. The other thing that is different vis-a-vis Quebec and the rest of Canada is that the Quebec government, and indeed many Quebecers, feel that one of the most important things governments do is to protect and promote French language and culture. And this is why there is a special kind of relationship with the Quebec state, and why Quebecers have developed a unique cultural identity in North America. And finally, and sort of pushing that even further, is la question nationale. And so our politics are defined not only by questions that have to do with the economy and the role of the state, but more importantly, who are we, right? Who are we in Quebec? And la question nationale is whether or not Quebec as a nation is what that definition means, and what that means in terms of the relationship with the rest of Canada, and indeed the role of the state in Quebec vis-a-vis the rest of Canada as well. So these are the things that define Quebec politics, and as we'll see, they're very important as well in not only the development, but the actual contours of health policy. So one of the reasons that there's a direct connection between this political landscape and health policy is that health was one of the most important items, right, in the basket of modernization of Quebec's state and society. So just as it would have a huge impact here in Saskatchewan, the kind of creation of our healthcare state or our healthcare institutions were directly related to this very rapid modernization of Quebec's state and society. And today, as we're reassessing really what that relationship is between state and society, and also the relationship between Quebec and Canada, healthcare is, again, taking up a lot of space in that particular debate. So today, what I intend to do in this presentation is give a very brief overview of the system, right? Just kind of sort of say this is the way the healthcare system works, some of its particularities. Then go into a little bit more on the things that I'm interested in, which are the historical overview and evolution of that system, and finally some of the political importance of the transformation and recent changes in the system. Okay, so that's where I'm going to take us in terms of this journey as we talk about and try to learn something about healthcare policy. So let me just start. This is going to be a very, very brief overview of the system, and just remind you that one of the most important features of the Quebec healthcare system is that it is an integrated system functionally, and that in Quebec our healthcare and health policy is in fact directed by or part of a larger department or ministerial function, the Ministère de la Santé et des Services Sociaux. So from the get-go, Quebec's healthcare policy has always been seen as part of a larger policy and the integration of health and social services, right? So that's a very important distinction that comes to us from the very beginnings of public insurance in Quebec. This is the sigle, the emblem of the ministry that's responsible for its operation. In effect, there are three parts to healthcare in Quebec. Unlike other provinces, we have three. The first is hospital insurance, which is regulated or known as the Régime d'assurance hospitalisation, which is administered by the Ministry of Health and Social Services and decentralized to its regional and local agencies. I'm going to put up the organigramme in a moment so you'll see that. The second part is medical insurance, la Régime d'assurance maladie, which is administered by a parapublic agency known as the Régie de l'assurance maladie du Québec, or RAMQ as we call it in Quebec. And what RAMQ main claim to fame is as well is that RAMQ is the organization that directly negotiates with physicians in terms of the fees, right, in terms of their fee structure. So it has a very important role to play in Quebec's healthcare system. And thirdly, we have pharmacare in Quebec, which is known as the Régime général d'assurance médicaments. And this has been in place since 1997. So hospital insurance has been in place since 1961, medical insurance since 1970-71, and pharmacare since 1997. What's interesting about the pharmacare program in Quebec is that it's universal, but it is what we could call a public-private, I wouldn't call it partnership, but coexistence in that people need to be covered. So it's a universal program, but they can be covered either by public or private insurance. So that's it allows for both of those kinds of insurance mechanisms to function. But it means, in effect, that Quebecers, unlike people in other provinces or most other provinces, do have access to some kind of an insurance for their pharmaceutical outpatient. All right, so this is the organigramme I promised you. You know how it is in Quebec. It's very, what was it, Cartesian. That's the word I was looking for. So when I thought Cartesian, I better show the organigramme, right? So this is the interesting way that it can be looked at. What's most important, though, so there's this stuff, I don't know if there's a pointer here, but what's most important is obviously that the top half is really about the ministry and how the ministry, in effect, how the ministry is organized. But what's actually most interesting is the bottom part, because the bottom part is replicated. So that bottom part is replicated across 95 different areas in Quebec, which are organized around something called the CSS3, the Centre de Santé et de Services Sociaux, which are the local function, or the regional/local functions of how healthcare services are actually organized and delivered in Quebec. And so each one of these CSS3, so it's because it's CSS3, so we call it in English, normally have in their network a hospital center, a long-term care center, readaptation or rehabilitation centers, centers that have to do with social service organizations targeted to the general population, but also to youth and vulnerable youth, And also within this is where, in effect, resources are allocated in terms of funding for those different parts of the puzzle. So this is replicated across Quebec and serves as really the modules, right, the nodes of the organization and delivery of healthcare services. I want to point out one thing that's interesting about Quebec is I mentioned the RAMQ. Physicians have a different relationship to the state than they do in other provinces. And part of it is due to, I guess, the divide and conquer strategy on the part of the Quebec state. But basically, physicians in Quebec, in order to be able to bill the Quebec government, need to belong to a federation, which kind of functions like a union. In the sense that they need to belong to it. It's not a voluntary organization. And that the federation or the /union is divided by function. So there's a federation for generalists, la Fédération des médecins omnipraticiens. There's a federation for specialists, la Fédération des médecins spécialistes. There's also a federation for residents. And the students have their own federations. So each of the component parts of physicians who offer services in Quebec have a different structure of negotiation directly with the RAMQ. So they don't all negotiate as a group. The other thing that's important about physicians in Quebec is that in order to practice in Quebec, you need to be part of something called a Plan Régional d'Effectif Médical, or plural, which means that you need to be able to, or the government decides how many physicians doing what you do or want to do there are in each region to decide whether or not you can actually practice. So this affects mainly new physicians, so physicians who are coming out of medical school, in effect, about the extent to which they need to think about going to an underserviced area to be able to practice from the first 3 to 5 years of their practice, or otherwise take a hit in terms of the reimbursement. So the PREMs have become another way of, in effect, the state exerting control or at least influence on physicians in Quebec, and it has a monetary, obviously, impact as well. The other thing that's interesting about physicians is that physicians don't tend to be entirely under a fee-for-service basket or a fee-for-service way of getting remunerated for their time and their services. In effect, many physicians, even if they will have the majority of their income coming from fee-for-service, may also have a portion of that income coming from an alternative mode of payment. For example, you can be a physician in a community clinic, a CLSC, and receive a salary payment. More and more women who are general practitioners like this because you get benefits and time off and life and all of that that many women but even many specialists have also moved towards a blended remuneration system. So this is, obviously, fee-for-service still dominates, but it's not the only way that doctors, in effect, build up their income. The impact of all of this is that you have slightly different kinds of access and costs associated with the Quebec system. Overall, health costs tend to be lower in Quebec than in other provinces. Total expenditure in 2012 per capita was slightly lower than the national average, and because, mainly due to the fact that we have primary care program, out-of-pocket or private expenditures were lower for Quebecers than elsewhere. In terms of access, most Quebecers would say that they're well-serviced. However, 25% have reported to Stats Canada that they do not have access to a regular family doctor. So I'm going to talk a little bit about the reorganization of the primary care health network a little bit later on, but it means that 25% of Quebecers aren't signed up, if you will, with one of these primary healthcare groups. It doesn't mean that they're not getting care if they show up at a CLSC, for example, so there are alternatives to the emergency room, but it means that they don't have a regular family doctor, and that's different to the average across Canada. And for specialists, more Quebecers have claimed that it takes longer to see one than in the rest of Canada, the Okay, I have a series of slides that I'm not going to speak to. It's just to show the difference in slides. So just to show the difference in a more visual form that you can see here, the per capita expenditure being lower in Quebec than in other provinces. You can see here the differential, which is about access to care. This is about the consultation of a physician over a 12-month period. And again, Quebec is slightly lower, and it has no correlation with the cost structure, but still, the effect happens to be at the bottom on both of these particular charts. The distribution of physicians is also interesting because one of the things that this points out is that there is not necessarily a shortage of physicians in Quebec. Quebec physicians are not reimbursed to the rates that are as high as in the rest of Canada. So that's an important thing to remember. Part of the reason why in Quebec we do have lower costs is that physicians do not earn, at least in terms of their fees, right? Actual fees tend to be lower than they are in other provinces across Canada. I just put a couple of slides in this because we'll talk about the Shaoli ruling and also because of the wait time, part of the wait time encouragement that had been part of the 10-year accord. In Quebec, we haven't seen terrifically good outcomes in terms of reductions on wait times in the 3 areas that were targeted by the Shaoli ruling, in fact. So here is hip replacement, which again is not, the figures are not that great if you think about should be going the other way, in other words, and it hasn't happened. Things are a bit better for cataract surgery, but it's not as though this ruling or that accord had this tremendous impact, right, in terms of these numbers. Okay, so that's like the briefest of snapshots on the healthcare system. And what I want to also, or what I want to turn your attention to now is why the system is different by looking at why history matters, right, and why history matters as well in how we think about health policy. So in Quebec, what's interesting is that I always think about Saskatchewan having like its revolution, right? I don't know how quiet it was, but a little revolution, a mini revolution in the 1940s. In Quebec, we had a quiet revolution, a so-called quiet revolution, but it emerged from something deeper, and that was from 1943 until 1960. Union Nationale was in power in Quebec. Union Nationale was a very conservative government. It was not just conservative; it was very nationalist. We call them les bleus. We call conservative nationalists the blues because le ciel est bleu et l'enfer est rouge. The sky is blue and hell is red, so that means you should be voting blue. Get it? Yes, that's what Mr. Duplessis counted on. And he, in fact, what's interesting about the way that the Union Nationale conceived of its relationship to Quebecers as a government, but also to the rest of Canada, is that government should just get out of the way. And one of the things that Duplessis really thought was the only way that Quebecers could maintain their distinct identity was through protection of language and religion. And in order to do that, governments had to get out of the way and not, in effect, reform, quote unquote, the status quo. And that's why, so, you know, this is from the 1940s, Coopération ou l'assimilation. This is after the conscription crisis. Duplessis makes a great, terrific, large majority in 1943. And the idea was that we want to stay the way we are. And the way we are is a Catholic and French society. And so, in effect, that was his message inside of Quebec. And to the rest of Canada, and especially to Ottawa, was we don't want the federal government interfering with what we do because we don't want we're not interested in expanding the reach of the Quebec state, and we're certainly not interested in having the federal state interfere with what we do either. So that was very much a double-edged kind of a message by Duplessis. I just put this up because avec Duplessis, c'est le progrès. With Duplessis, it's progress, and most people who consider themselves progressive would say it's actually the opposite, but it depends on how you define progress, right? So that's it. Okay. In this way, what that meant for healthcare was that the delivery of healthcare until the 1960s remained in the hands of the church. And so it was, in effect, the the church became, or was, the main instrument for the delivery of social needs. There was no Ministry of Health, there was a Ministry of Public Health, but in effect, delivery of care was through really church-run hospitals. So this is from the Laval archives, where the sisters are, this is a nursing class being taught in the bottom left-hand corner in Quebec. So basically, the church was responsible for education, for charity, for orphanages, and for healthcare. There was a reform element emerging, but the church really saw that it was its mission to provide this kind of care. Doctors were obviously part of that, but they remained in the private realm, private practice, etc. And the provincial state took a very limited role in terms of all kinds of social policy that was buffeting North America in general. Quebec was staying out of it. That changed, and it changed not exactly for the same reasons that change happened in Saskatchewan, but it did change from a push from the left. And basically, Quebec's own society was rapidly changing after World War II. So it wasn't as if, even though Union Nationale was in power, it wasn't as if there was status in society. Things were changing very rapidly. The labor movement was becoming much more important, much more also vocal in agitating for economic and social reform. A strike like the asbestos strike in 1949 was very important in that regard. A new middle class was developing from Quebec's universities, technocrats who would build the Quebec state. There was rapid urbanization after the First World War, but even more so after the Second World War. And the emergence of nationalist thought that emphasized Quebec's cultural specificity as something that was not attached to religion. And that made a huge difference as well. And two of the main proponents of this idea were two people who became proponents themselves, and that is to say René Lévesque and Pierre Trudeau, who both, in their own way, were rebelling against the idea of how we define cultural specificity, right? That it's no longer about the church, it's about something else. What is it about? A nationalist thought. In Pierre Trudeau's case, that was a larger nation, known as Canada, and René Lévesque's. So this led to the Quiet Revolution, and just, how before the earthquake happens, the plates are shifting, and then the changes occurred when Jean Lesage became the Premier of Quebec. Jean Lesage, by the way, had been a minister in Louis Saint Laurent's cabinet. So he was aware of what was going on in the rest of Canada. He was aware of how the federal government could perhaps be a lever in trying to effect change in Quebec as well. He brought his dream team, his équipe de tonnerre, to Quebec City, and decided to use that team, including people like René Lévesque, to take charge of social and economic affairs. And there's a new rhetoric in the 1960s. It's emerging in Ottawa as well, and the rest of Canada, of social security, of social rights. And he wants to bring that to Quebec, but have it as the responsibility of the Quebec state. So the key reforms are these, right? So we have economic reforms, the nationalization of key resource industries, social reform. The first battle, the decisive battle, was about the secularization of education, called the Battle of the Bishops, with the bishops in Quebec, hospital and medical insurance, public pensions, and of course, but we're going to look at healthcare. And the first part of that is, of course, hospital insurance. So by 1960, when Jean Lesage becomes Premier, Quebec has still not signed on to the cost-sharing agreement with Ottawa. So it's the last province to do so. And Lesage has to do it because he uses it in the 1960 campaign, right? He says we have to move forward. For example, we need hospital insurance, right? So he uses it as a promise in the 1960 election. And so it's one of the first things that's signed. It's really interesting. One of the first laws that this quiet revolution ends up with is a cost-sharing program with the federal government for hospital insurance. But more importantly still, not 1961 and the cost-sharing agreement, it's 1962, which is the Hospital Act, which in effect takes away responsibility for the administration and delivery of healthcare from religious communities. Right? So that's in effect like the real institutional change happens in 1962 with the reorganization of how this delivery of care in hospitals is going to be. The second thing is medical insurance. And if you read, it's very interesting, I'm not a historian, but I read biographies, it's really interesting because Lesage really felt that he had been kind of forced into signing on to that cost-sharing agreement on hospital insurance. Like it was just there and he had to sign on, and he wasn't able to really see whether Quebec could afford it and also whether or not it was really what Quebec needed. So when it came to medical insurance, which was obviously being debated at this very time, 1965, this is just after the doctor strike here, the Hall Commission has reported and the federal government is actually talking about cost sharing with the provinces. Instead of jumping into it, he appoints Claude Castonguay, which is this quiet-looking man at the bottom here, to put a research committee together to sort of see what we were getting into, in other words, in Quebec, what this medical insurance would entail and how to develop a plan. Castonguay was an actuary, right? He was one of these, he's like the perfect actuary, insurance type. He had been a player in the pension reform. He'd gone up to Ottawa with Jacques Parizeau and Jean Lesage to negotiate pension reform and the sort of separate, the asymmetrical Quebec and Canada pension plans. And in his report, which was really interesting because he was not a very political guy, right? He just said, if we're going to have a medical insurance plan, we have to make sure that it responds to the context and needs of Quebec, which he said were tremendous. So when he went across Quebec for this commission, or this committee, and he was like basically shocked to find the extent to which Quebecers were not getting the care they needed, in which they had problems in paying for medical care and problems in accessing it. So he was quite shocked by it. Now, he doesn't look very feisty, but he's our father of Quebec Medicare. Not Tommy Douglas. No. Quiet actuary. We call him the quiet revolutionary. That's what he is. So he's our father of Quebec Medicare. Many people would consider him the father of Quebec Medicare. One of the reasons we consider him the father of Quebec Medicare is that when the Liberals came to power in 1970, they actually came back to power. They came back to power. They invited him to run for office with saying, look, Mr. Castonguay, run for the Liberal Party, win, and then you can implement your own report. How many people get to do that, right? You can actually implement your own report. So he runs for office, wins, and is named Minister of Health and Social Services, so, right, amalgamation of health and social services. And what's interesting is that the plan that Castonguay's team comes up with is different than what you see in other provinces. It institutes this different separate payment schedules with the federations. The federations are created in the late 1960s. And it prohibits extra billing by physicians. So it really puts the squeeze on the profession. Very different kettle of fish than you'll see in other provinces. And it also has this distinct idea of health and social determinants of health being twinned together. Quebec doctors go on strike. So this is the other thing we have in common with Saskatchewan, a doctor's strike. The doctors, however, did not choose their timing is everything, as they say in politics. Doctors did not choose their timing very well. They went on strike, and 2 days later, the October crisis hit. 2 days later, James Cross was kidnapped. So as you know, 2 people were kidnapped during that crisis. One died and one did not. But Quebec was engulfed by it. So the strike only lasted 17 days, in part because the timing was just awful, but also public opinion turned against them. Some of the same things you see happening in Saskatchewan happen just in a much faster way in Quebec. And also, the Quebec government has another thing up their sleeve because the War Measures Act has been implemented. And so they're able to pass an emergency measure to force the specialists back to work. And they do that in the end of October. Many specialists voted with their feet. So many specialists left Quebec as a result of that because of the extra billing was very important, right, for specialists as a condition. It's happening across Canada. They were not allowed to do that. So many did, in fact, vote. What comes after that in 1971 is the administrative changes. So just like we had the cost-sharing program for hospital and then the administrative changes, same thing happens here. We have Quebec signing on to the cost-sharing program and then the administrative changes that are going to be able to make that happen. And what these administrative changes do is reinforce that connection between health and other social determinants, promote primary care, integrated healthcare systems, CLSCs into place, these local community and service centers, which have now sort of been amalgamated into the CSCs, threes, public health departments, and regional health boards. So Quebec, from the beginning, has public health departments and regional health boards as part of the organization of healthcare. Since then, I would say we're in an era of transformation and change, right? And I think that's true of healthcare systems around across Canada. In Quebec's case, it's always, I think, or very much intersected with these two things. Who is in power and what the government in power sees as the relationship between the state and society, and second of all, the relationship with the rest of Canada. So both of these things come into play in terms of these transformations. And as in other provinces in 1980s, there's huge economic problems, economic recession, restraint in the growth of social programs. And in 1990 is exacerbated, obviously, by the changes to transfers to the provinces, though these transfers had already started to decline by the late 1980s, so it's sort of like building up to the 1990s. And Quebec, at the beginning of the 1990s, a new government comes into office. The Parti Québécois comes back into office in the early 1990s and starts experimenting with ways of trying to control its health budget, capping physician incomes, which didn't work out, particularly for specialists, limiting how much physicians could bill RAMQ, and the PREM system of trying to encourage physicians to move into underserviced areas. The other thing are things that, so those may have been not exclusive to Quebec, but sort of spearheaded by Quebec. Other provinces turned to these as well. In fact, in British Columbia, on the moving to underserviced areas, for example. But the other things that Quebec did are seen across the provinces, reducing medical school enrollments. So that was very, very precipitous reductions across medical schools in Quebec, and the closing of hospitals. So not as many hospitals closed as in Saskatchewan, because I think you guys have the record. Number of hospitals closed in the 1990s. Yeah, small. Ours were big and they were closed. The hospital I was born in was closed. I'm sure a lot of people say that, right? Yes, right. Yeah, and not just because it was called the Queen Elizabeth Hospital. That's not why they closed it. The Royal Victoria survived, not the Queen Elizabeth. Yes. But these are the things that happened across Canada as well. And of course, as in other provinces, we love commissions. We love them so much we have to have more than one, right? We can't just have one commission. We have to have many commissions. So this is from Doug Angus, our colleague at the University of Ottawa, who says this is what we do in Canada. We take two commissions and call me in the morning. That's what you're supposed to do. So here's two commissions that started in Quebec, which had some actually interesting but different recommendations. The first was the Rochon Commission, led by Jean Rochon. So interestingly enough, Rochon becomes the Minister of Health after he writes his commission report. That's another kind of a thing that happens in Quebec. He calls for a virage ambulatoire, which has become the theme of health reform since the 1990s. It's this idea of move towards ambulatory care, the idea that hospitals need to be rethought. We need to rethink how we deliver healthcare, right? Reimagine the delivery of healthcare. Virage ambulatoire, and a new government initiative that, in fact, the Liberal government is forced to implement, which is called Une réforme axée sur le citoyen, patient-centered care. Way before it makes the headlines elsewhere, but that was, the beginning of this idea of patient-centered care. In 2001, the Clare Commission, Michel Clare, who had also been the Minister of Health, in fact, he'd been the Minister of Health before he ran the commission, so it's a little different, recommends the reorganization of primary care, and this is the commission that leads to all of the reorganization of primary care in Quebec and the formation of family group practices. So the idea was to roster people into family group practices to provide care, but not, it's like not going the full Monty to the British system because of not having capitation. Still relying, for the most part, on fee-for-service. And, of course, the problem is that Quebec's physicians are, there's about 250 GMFs or FMGs now in operation. The government would like to see that number rise to 300, and that way we can get rid of the 25% of Quebecers who still can't find them. Okay. The other thing that has happened since the healthcare system came into being is, of course, so on the one hand, what governments have done, Quebec governments, but on the other hand, the relationship with Ottawa. And here, the Canada Health Act, I talk about it in the paper, was, and Quebec was obviously not the only province, but was very much seen as a piece of federal intrusion into Quebec affairs, right? So Quebec was not the only province to say that. But it meant that Quebec tried to, in effect, stretch how the federal government would react. So for one thing, a really important trial balloon in 1991 was floating the idea of emergency room user fees. And this was the Liberal government, Bourassa II, as we call him, the second time Bourassa was in office. And it was pretty serious, but the government backed down. The government backed down because of public opinion, but it would have been quite a direct sort of putting down of the gauntlet towards the federal government. In 1997, Lucien Bouchard is the premier, and he's part of the provincial resistance that kind of mobilizes itself against the federal cuts at the same time that the Forum on Health is reporting. And Lucien Bouchard actually becomes one of the largest players in terms of the provincial resistance as mobilized against the federal government. And 2001, the Parti Québécois starts its, banging the drum on fiscal imbalance. So the idea that Quebec's, wait for it, not getting its fair share out of the Federation, in effect because there is a dédoublement, chevauchement, there's too much overlap and too much repetition in terms of what the Quebec government does vis-a-vis the federal government, and the federal government should just move out of healthcare and let Quebec take care of its own healthcare, and we would save a lot of money, and it would be more administratively streamlined, and also allow Quebec to become, which is really important for the Quebecois government, autonomous in its sphere of jurisdiction. It's part of the fiscal imbalance story. The main changes, though, that have happened in Quebec healthcare scene have happened through a Liberal government, however, during the 2000 decade. Because it was the Liberal government in Quebec that negotiated the 10-year accord with the federal government, that defended Quebec interests in Shaoli case, and also that commissioned new healthcare reports that are leading us into what I would call where we are now in terms of healthcare. So that famous 10-year plan or 10-year accord that was signed in 2004, the way it was sold in Quebec, so everything has to be packaged, the way it was sold and packaged in Quebec by Jean Charest, who was the premier at the time, was that it was an asymmetric entente with Ottawa. Okay, but the only way it was an asymmetric entente with Ottawa is that Quebec wasn't part of the Health Council, so it didn't sign on, nor did Alberta, so two provinces that didn't sign on. Quebec retains its autonomy over the specifics of the funding agreement. Most provinces feel that they have the autonomy over the specifics of the funding agreement as well, so it's unclear whether there's a difference, but it was sold in Quebec as a model of asymmetric federalism. This is Jean Charest going out there and fighting for Quebec, so that's how the 10-year plan was sold in Quebec. The other thing that happened was the Shaoli case. So, can't go into detail here, it's in the paper. What happened in Quebec is that a legal case was mounted against the Quebec government based on the question of waiting times. So, in this case, a patient named Georges Zaliotis and a physician named Jacques Shaoli were the plaintiffs in a case that actually were challenging the legality of Quebec's laws, healthcare laws, on whether or not they could actually prohibit duplicative private insurance and get private insurance for things that are publicly covered. And in effect, in Quebec, they lost twice, not once, but twice. Quebec Superior Court, Quebec Court of Appeals. Both courts unanimously rejected very kind of strong decisions against the Shaoli case. However, it did go to the Supreme Court of Canada, but it was not rejected. It was actually approved. Sorry, there's a big typo there. It was approved by a thin majority under the Quebec Charter. So the very thin majority ruling, which said that, in fact, the plaintiffs have a cause, but only under the Quebec Charter, so it was only applicable to Quebec. This again, depending on how you sell it, right? So the first thing the Parti Québécois said, they were in opposition, was notwithstanding clause, right? So Quebec Liberals did not go there, but they were in effect talking about this as an example of federal intrusion. National institution actually telling Quebec what it can or cannot do. That's the way it played itself out in the Quebec case, even though there are many people in Quebec who actually were sympathetic to this idea of expanding private insurance. What the Quebec government did as a response was something called Bill 33. And Bill 33 is interesting to look at because if other things happen in other provinces as a result of Shaoli, there may be also the need for legislative responses. What Bill 33 did, though, was to try to contain the response of the Quebec government to zero in on exactly what was at stake in the court case. So first of all, to implement a hospital wait time guarantee for surgeries in 3 areas. And even critics of Bill 33 say this is a good thing because we didn't have a centralized way of knowing about wait lists in Quebec, so at least now we do for these particular surgeries and for now some that have been expanded. There's been a ban on the duplicative private insurance for only these 3 targeted surgeries. Only these 3 targeted surgeries. And there's been the development of something called, very controversial, specialized medical centers to meet the expected demand for these services coming out of the first 2 parts of the law. There are 2 kinds of centers. One kind is affiliated. So affiliated means affiliated to the public system. So you have physicians who work in the public system, who work in these centers, and then you have non-affiliated, where physicians who have opted out of the RAMQ, who do not take public payment, are able to work as well. Bill 34, so there's a companion piece to Bill 33, which is Bill 34, which did 2 things. It expanded the number of elective surgeries that could be in this basket of services in the medicalized centers. So now we're moving beyond, still electives, but we're moving beyond, some of them are electives, but we're moving beyond knee, hip, and cataract to mastectomies, hysterectomies, bariatric surgeries, for example, and allowing for certain loopholes, sorry, there's a bit of a typo there, to allow some doctors to work in both settings. So the idea of Bill 33 was, we're going to keep the wall going between public and private, because physicians either have to opt in or opt out. That's been changed in some respects by Bill 34. And one of the things that's also been critiqued is that now only private medical centers can offer the operations or surgeries that involve overnight stays. They've also been expanding the scope of private medicine. The other impact of Shaoli, well, as you would think if you were in the insurance business, is that nobody's selling policies for knee, cataract, and hip replacements in Quebec because so the risk pool it doesn't make any sense for an insurer to do that. There's a lack of interest on the part of the insurers. There's difficulties in trying to coordinate the system. However, what Shaoli has done, the biggest impact of Shaoli has been outside of Quebec, and these copycat legal challenges. Now, in Ontario and Alberta and in British Columbia, the case is on extra billing and user fees. Right? And the day case is now going to be heard in September. These are cases, and what was important in the day case is, full frontal attack on the Canada Health. But the other thing that we have in Quebec is the mouse that roared. Monsieur Castonguay is back. And Monsieur Castonguay, the father of Quebec Medicare. Imagine Tommy Douglas doing this. The father of Quebec Medicare is now advocating for a private system. So it's kind of interesting. Yeah, it's like, oh, did I miss something? Yeah. Not only that, but he's doing it by, in effect, criticizing the Canada Health Act. He sees the Canada Health Act as the biggest barrier to effective health reform in Quebec. The Canada Health Act that, in effect, restricts what provinces can do. And that, to him, as a quiet revolutionary as well, right? The idea of autonomy in your sphere of jurisdiction is really important, and that to him is also a big impact of the Canada Health Act. So the Liberal government, after the Shaoli decision was released, decided they need to do something about healthcare. They commissioned a new report, asked Monsieur Castonguay to come out of retirement to write the report called Getting Our Money's Worth, and in it, Monsieur Castonguay was really unstinting in his criticism of and saying what was wrong with Quebec's healthcare system. Made some really loud points. One was we need to set limits on public budgets for healthcare, so much money and no more. New funding arrangements for hospitals, which are actually now being studied. He's very much a fan of the British system, the money following the patient. That's what he suggested would be the best way of reforming funding of hospitals, but also the need for new revenue streams. The public system cannot pay for everything, is his mantra, so we need new revenue streams. We also need to introduce insurance principles into the way the healthcare system is run. Monsieur Castonguay left government to work for an insurance company, La Laurentienne, and he became, in fact, one of the biggest insurance companies in Quebec. Right? So he's very much in an insurance mindset about what should be done to reform the system. He wants to see deductibles, user fees, alternative payment forms, anything you need. He wants to go back to the principles of insurance. And to allow a greater role for private health insurance. The only way he sees that can be done is if you bring down the wall between opted in and opted out doctors and allow them to be able to practice in both settings. That, he says, will bring up the demand for private delivery and also then make private insurance a reality, right? Because then you broaden what can be covered and the other thing that's happened is that the Quebec government started getting tough with the Canada Health Act as well. And so what we've had, the Liberal government in 2010, their famous tough love budget was all about healthcare. So this is post-recession. What's our biggest line item? It's healthcare. We have to do something. Raymond Bachand, who was a Liberal Minister of Finance at the time, decided that there were going to be two things. The imposition of a health premium, right, the way we have health premiums elsewhere in provinces across Canada, and a health deductible. And the difference between the two is really important because the health premium is sort of like what you have in place in British Columbia and Ontario. It's a little different the way it was conceived in Quebec because it was conceived as a poll tax, $200 flat fee for every user of the healthcare system. That's a little different than the way it's conceived in other provinces. And the other thing that was different is that it was the money, which was just under $1 billion, was going to be earmarked for a special innovation fund in which healthcare establishments could compete for the money. So it wasn't going to go into general revenues for healthcare. It was going to go into a special fund for innovation. And that's the way it would have played out. I say would have played out because the Parti Québécois ran their 2012 election campaign on getting rid of the health tax. So that's the way it would have played out, going up to $200 as a poll tax. It would have been $200 for every, some exceptions. The other much more controversial trial balloon was the ticket orienteur or the healthcare deductible, which would have imposed a deductible of $25 for every medical visit that one had in Quebec. It would have been adjusted for income, adjusted for a maximum for people who are under chronic care conditions, and it would have been assessed on income tax. So very clever. The Quebec government said it did not have an impact on the Canada Health Act because it wasn't at the point of contact with the health system. Right? It was retroactively assessed at the end of the year. Regardless, Bachand and Bolduc kind of lost their nerve. They realized there was a huge outcry about, wow, how much is this going to, people are already paying really high taxes, how much more is this going to cost? And after extensive consultations with the healthcare community, including policy people, not just actual deliverers of service, they decided not to move forward on this measure. So they basically choked or blinked. But it was a pretty serious trial balloon. They had even costed it out, right? It was in the estimates about how it would actually function. So they were serious about it, about how this would work. And it's really not clear whether or not, whether or not it would have had something to do with the Canada Health Act. However, peu importe, the Canada Health Act is now part of the debate about healthcare reform in Quebec. For most Quebecers, the Canada Health Act does not really symbolize their attachment or their relationship to healthcare in Quebec at all. It's not a symbol of identity for Quebecers, and politically, it's used as basically part of fiscal federalism. It's seen as an instrument of fiscal federalism. It is not seen as a symbolic or unifying kind of, does not have that function in Quebec. In fact, Castonguay himself told us it was a dysfunctional statute, right? It was impeding provinces being able to do what they needed to do, impeding Quebec's ability to be autonomous in its sphere of jurisdiction. Monsieur Bachand said the same thing, so the Liberal government, this is not the PQ, right? Monsieur Castonguay was a Liberal minister, and now we're talking about a Liberal health minister saying the Canada Health Act should not impede on our own solutions for healthcare reform. And in effect, when he was called on the health deductible, he actually said it's not. It's actually a positive thing for the healthcare system. It would also be a good model for the other provinces. So we'd like to go ahead and try it here in Quebec to see if it works, and then other provinces can adopt it. So this was it was his gift to Canadians. That's how it's being sold. Okay, so there's politics in healthcare. And the politics for the Quebec Liberal Party have been, in the past decade, gone back to a two-party system in Quebec. Some third parties voting, but really much a two-party system, which is also a system about left and right. So the Liberal Party has, in effect, taken on the center-right discourse. And the engineering of the state for the Quebec Liberal Party was really important in 2003. And you could say that they tried, but failed to completely re-engineer the healthcare system the way some people in the Liberal Party would have liked to make it much more of a system that was private, that open to private delivery and financing. But it still is part of the discourse of the Quebec Liberal Party as in terms of autonomy, right? That Quebec needs to have this special asymmetric relationship with the rest of Canada, that it's part of the autonomy discourse. For the Parti Québécois, it's a little different. They, ironically enough, support all of the core principles of the Canada Health Act. They just don't call it the Canada Health Act, right? In fact, Canada Health Act is not mentioned in Quebec's laws. Very interesting, very passing reference. They support universal, accessible, and public health insurance. It's very interesting. They're much more CHA inspired than the Liberal Party, which is more Canada inspired. So it's just bizarre the way the lines fall. But the Parti Québécois says we don't need the Canada Health Act. We don't need Ottawa to tell us that we want a healthcare system that's universal, accessible, and public. Right? That's our. You're stealing our line. That's our line. It's not their line. And also the question of the fiscal imbalance, which has now come back. Because everything comes back, right? It's like the zombies. It's come back and is now going to be a central part of the 2014 election campaign that's going right now. Healthcare is going to be part of it. Fiscal imbalance in terms of healthcare is going to be the biggest message. Very brief conclusions because I know I've run out of time. We went over some of the distinctive developments, social explanations, bureaucratic explanations, political reasons that we have a different kind of healthcare system in Quebec, and of course institutional ones that derive in many ways from federalism. More emphasis from the beginning in Quebec in terms of, so at the moment of creation of the healthcare system in Quebec, the idea of a more interventionist state, social democratic discourse, and this national identity part, right, where the nation is not in Ottawa, but in effect being protected by the Quebec state. The asymmetrical federalism idea, the idea that Quebec is different and therefore its relationship to the Canada Health Act, its relationship to Ottawa in this policy domain is very different. I put in the quote from Mr. Romano, the federal-provincial hollering for Quebec is not just about the money, it's also about who gets to make the rules. The struggle for autonomy in this regard. And these are the key issues that I see on the agenda. Continuing primary care reform. We haven't figured out the answer to our aging population yet, only that we have, the economists telling us they're going to, like the dog that ate Christmas, but we don't have any real reforms happening in that regard, so this is a big unfinished business for Quebec. We do have, on the other hand, this end-of-life legislation that you may have heard about that is now died on the order paper, but that will come back if the Parti Québécois is re-elected. The remuneration of physicians, the Quebec government, this Quebec government, Parti Québécois government has made it clear that the days are over, right? This is it, no mas, as they say, for the physicians. The financing of hospitals, an expert report has just been tabled. It was partly written by someone at McGill, Thompson, on trying to move towards the activity-based financing. The oversight of our mega hospital projects, not one, but 2 super hospitals. Okay, in Montreal, because so that's a huge responsibility for the government. These investigations into the centres médicaux spécialisés, about whether they're actually functioning as they should, and the wall is still there between public and private. the countdown to the end of the federal escalator. All provinces are trying to manage this. And depending on the party in power, so it does matter who's in office, whether we are going to be talking about alternative revenue streams, if Liberals are in power, or for whether we're still talking about imbalance. Just to end, there's an interesting relationship between doctors and politics. So as far as I can tell, and you guys are going to tell me if I'm right or wrong here, whoever noticed, there's only one other province where you ever see a health minister being a doctor. Is Nova Scotia? Yes? Quebec, it's like par for the course. Jean Rochon, public health doctor. Regina, who's the current Minister of Health. Sherbrooke, University of Sherbrooke Medical Center, primary and public health both. Philippe Couillard, neurosurgeon, who's now not only was health minister, but is now actually the head of the Liberal Party in Quebec, fighting that election. Yves Bolduc, the former Minister of Health for the Liberal Party, primary care physician. And Dr. Gaëtan Barrette, who is the former head of the Specialist Federation. So he's tell what side of the bread. He's buttered on, right? Who was running for the third party, Coalition Avenir Québec, but who is now running for the Liberal Party. So that's the alpha and omega. I don't know, but it's a really interesting connection. Thanks very much.
Well, thank you very much, Antonia. Now I think we'll shift to Saskatoon and see if there's a question there first, and then we'll come back to Regina.
Yeah, we do have a question, Greg.
Bonjour Antonia, c'est Daniel Bélan.
Bonjour.
Thank you very much for. I'm doing fine. Thank you for your talk. Very, very good talk. As I expected, my expectations are always high when I come to attend one of your talks. So you met my expectations. And I have two questions for you. The first one is about the impact of Quebec in the development of Medicare across the country. And, there's a book by Jerry Boychuk that appeared 5 years ago that put, the argument is very much centered on the role of Quebec within the development of Medicare in Canada. And I want to know what's your take on this book, because I don't think I've ever read a book review or anything. I know Greg Marchildon reviewed the Boychuk book, but I want to know what's your take on his argument about the role of Quebec in the development of Medicare in Canada. Just like traditionally we emphasize the role of Saskatchewan, and now Saskatchewan and other provinces pressure the federal government to enter the field and so forth, but Boychuk stresses the central role of Quebec. And I would like to know what your take on his argument is. And the other question concerns the Charter of Values, the Quebec Charter of Values that we have been talking a lot about, and we'll hear about even more during the campaign. Will this, if it's ever enacted, if the PQ gets a majority and they enact it as is, they enact their current plan, will this have any significant impact on healthcare practitioners in Quebec? These are my two questions, hot topics. Thank you.
Okay, thanks Danielle for bringing up something I didn't want to talk about, which is the Charter of Values. So just as you know, the Quebec government, the Parti Québécois government, before it called this election, had introduced the idea of a Charter of Values, which had three parts to it. It was about having a secular state, having a gender equality, and also this idea of a definition of Quebec culture. And on the question of the secular state, the idea was that people in institutions that represented the Quebec state should not be wearing ostentatious symbols of their religion. And so the question is, what's an ostentatious symbol? Oh, there was a little guide. And who works for the Quebec state? So the idea of that had been considerably enlarged from the recommendations of another commission, the Bouchard-Taylor Commission, which had reported that it felt that there should be perhaps the removal of these ostentatious symbols for people who were symbolizing the power of the state. So judges, policemen, who work in penitentiaries. No, not teachers, not for Bouchard Taylor, no. So this was expanded then through the charter to include exactly public school teachers, university professors, and people who work in healthcare establishments. So there, the pool gets suddenly a lot bigger, right, and affects a lot more people, not just the people who are wearing these symbols, but the people who are receiving services from them. So as you know, there's quite a split in public opinion in Quebec on this particular issue. The split goes every which way, but it tends to break down on linguistic lines. That's one of the ways that the split breaks down. And the impact, of course, would be very great. It would be great across Quebec, but it would be especially great in Montreal, where we have institutions, healthcare institutions, that service a great number of populations who are wearing these religious symbols, but are also staffed by people who may be wearing some of these symbols. And I mean, these symbols are not, it goes from everything from the kippa to chador. It's a huge range of what's considered an ostentatious symbol. So obviously it would have a huge impact. There have not been serious studies that have been done yet. There have been some, lots of opinion polls, but lots of surveys within. So there's been a survey within the MUHC, for example, that says that this would be a huge factor for many people working there, and that people who are working there may want to reevaluate if they want to stay or not. The Conseil du Patronat, so our committee or the council that is the voice of employers in Quebec, also had a survey that suggested that many of their employers in Quebec are worried about what the impact would be for them as well. So it's not an issue that's been resolved. And the interesting thing is that individual universities and individual health centers have come out against the charter, but we haven't as yet had federations of these establishments have not yet, sort of the peak associations, have not yet made up their mind. There have been public hearings. Public hearings are now over, and of course the election is taking place. That's going to be the decision. But I think we can expect that if the Parti Québécois government returns with a majority, they would need a majority to get this through, and they in fact do intend to do it. On the other question, which is a question that's just one of those, I'm not an historian, so I always kind of like feel like this is not, I shouldn't be trying to think about what would have happened, could have happened, or whatever. But from my understanding and analysis of that period in Quebec and Canadian history, the primary motivation of what was going on in the debate about Medicare in the federal government, at least, really did not have to do with Quebec. So it was, there was a lot of division in the Liberal Party and in the cabinet on this issue, but ex post facto, I don't see that Quebec was part of that debate, whether or not this was somehow a way of making Quebec become a better part of the Federation, whether it was part of Pearson's What Does Quebec Want. I don't think that that was the primary motivator of what was going on. And from the Quebec point of view, it certainly was not. So the idea in Quebec was, let's not be forced to sign on to this cost-sharing program unless we know exactly what our needs are in healthcare. That was the line that Lesage gave Castonguay when he sent him on his fact-finding commission in 1965, 1966. And again, when he did a second commission, because there's never just one, there's always two, in 1969-70. So the idea was, how do we fashion a healthcare system that responds to the needs and capacity? So in other words, I don't see Medicare as a nation-building exercise.
Down with the Boychuk thesis. Okay, who's next?
Okay, sure.
Okay. Again, thank you, Antonia. That was great. I have a real interest in. I knew that social services and healthcare were linked in Quebec. I did not realize it went back to 1971. Pop health researchers always talk about the only way you're going to get determinants of health taken seriously is to link it with health and healthcare and all of that. At the same time, the fear is always, if you put the two together, healthcare is going to eat the social determinants of health's lunch, and there will never be any money for social services. So I'm intrigued by how for 40 years, Quebec has managed to sustain the two. And is it the little tiny junior partner of healthcare, or is there actually some level of equality between the social and the healthcare?
Gosh, you guys want me to like peel off the dark underside of Quebec, but that's a very good question. Because that first Rochon report in 1988 argued exactly what you're saying. It's on paper, but it's not happening in practice. And the reason it's not happening in practice, it's not just the idea that healthcare eats up all the money that's allocated. It was, again, in terms of the implementation on the ground, where in many cases, general practitioners and specialists didn't want to play the game. And so, in effect, said, we don't want to be affiliated with your CLSCs, we don't want to be providing care in this way, we're going to set up our own private clinics, our own private practices, and people can come to us for care, and we'll send them to the hospital, and they need to go to the hospital. We're just going to bypass what you're doing. And of course, many GPs were able to do that, particularly in large urban centers, right? So where people had a kind of, access is not funneled, access is pretty dispersed when you live in a big city, and that's what happened in Quebec. The CLSC model of integrating health and social services actually works better in rural communities and where they're the only game in town. And their doctors are forced, right, to be part of the plan in some way, part of that regional organization or local organization, and where in effect people kind of get better access to care, at least to GP care, through the fact that the CLSCs are working with those. So yes, so that Rochon's first big report in 1988 was saying we have to go back. We haven't actually lived up to what we were trying to do. And the GMF reform of the Clare Commission, this idea of having rostering of patients, was sort of saying, well, at least can we just, okay, we can't get this perfect symmetry of health and social services. Can we at least make sure now that people get access to a primary care physician? Reorganization of the CSS3s was supposed to actually do that. And it is a better way because now it has, it's introduced these blended models for remuneration. It hasn't entirely happened, right? It's still an ongoing process, but it is in fact, you can write something into law, but the implementation depends on the stakeholders, and they didn't all want to play.
Saskatoon?
No questions here, Greg.
Okay, Regina, we have a question here, followed by a question.
Hi, thanks for your presentation, Greg. I'm from SIAS. I'm in the nursing division over there. My question is around Aboriginal or specifically First Nations health. I know that BC's went for full transfer of their First Nations and they're more integrated with the province over there. And I know that Quebec is the next province that's looking at that with their First Nations population, even though I think there's only probably about 100 and some thousand First Nations kind of registered First Nations people in Quebec. I'm just wondering what the relationship is now or what the future is looking like for First Nations and Inuit health in your province.
So Quebec, there are a couple of special specifics in Quebec. One is with the Cree population, and part of that is because of the specific relationship through the James Bay agreements. The other part of what Quebec does, and I mean I'm sure it's the same in other provinces that have remote Aboriginal populations, is the idea of trying to staff. So the incentive structures that try to staff or bring physicians to Aboriginal communities. It's very expensive, and it's done for most of the communities along the lower North Shore. The other part of the equation is the north, and that is another. So in Quebec, it's kind of divided because you have Aboriginal communities that live close to urban centers. You have Aboriginal communities that are a little more remote. You have the Cree special relationship, and then you have the north, which is another different kind of administrative basis. So the Quebec government tries to, they juggle with it. The First Nations part of it is mainly, apart from the Cree, is mainly in the same situation as what's going on with other provinces, right? So in that case. The Quebec case, though, it's replicated in other provinces, this problem of the remoteness of it. But the other problem for Quebec is the language component of it, because some First Nations are primarily English-speaking and some First Nations are primarily French-speaking. and in the north, that's replicated again. So there's another layer of complexity to the Quebec part, which is about access and language as well. So for example, McGill University Health Center is responsible for the English-speaking First Nations, right, in the remote area. So if they have problems, they come there because they can get service in English. So it's sort of another layer of the complexity.
Thank you so much for your presentation. I just want to pick up a little bit on Dr. McIntosh's question about the integration of health and social services.
Yes?
So talk specifically about two things that have sort of, I guess, died with the election being called. One you mentioned was the End of Life Care Act, and the autonomy insurance, which is, I guess, being discussed and Regina has advocated for quite strongly. I'm sort of wondering if you think that the integration of health and social services in Quebec has allowed those things to sort of get onto the agenda. I think to some degree in the rest of Canada, those are issues that we're not really ready to have a broad discussion about, I think, in some ways, whereas it's been sort of a mainstream, at least recently, a mainstream political discussion in Quebec.
Sorry, so say it again.
Has the integration of health and social services, has that facilitated discussions around the examples of using the End of Life Care Act and also the autonomy insurance?
That's a really good question. Yes, so to the extent that part of the end-of-life care issue is about sort of the autonomy of persons being able to make decisions about their health, but it's also about the dying with dignity approach. And it's also about so if we're going to give care to people in these kinds of situations, what's the best kind of care? In the health and social services kind of milieu, the idea is that the end of life should be seen as a social issue, not just a health issue, right? It's about quality of life. It's about making decisions about being comfortable with the last stages of terminal illness. So it's not just a healthcare question, in other words, because doctors are saying people come to the intensive care, we hook them up and that's it, right? That's our job. And the social services part of it is saying this is not the best way to treat an end of life issue. It's more complex than that. It depends on, this person's mental being, the whole thing. So yes, I think in that regard, there has been a conversation that's been it's stretched much more widely on that case. Absolutely.
I can take the prerogative of maybe asking the last question. No, this is a simple one. This is a very simple structural question. Antonia, do you think that Quebec actually has a regional structure which is its own model relative to the rest of Canada? You've got the Ontario model, and you've got the regional model that we have in Western Canada and in the Atlantic provinces. But in Quebec, you have the CSS-3s, you have the regional health authorities, and then you have the ministry. Is there enough independence and autonomy in terms of the CSS-3s that this really constitutes a three-layered cake that forms really a fundamentally different model of regionalization, or is it just a variant of the main model of regionalization?
Interesting, because again, the dark underside. Okay, so I'm supposed to say, of course it's a different model. It's a Quebec model. But on the other hand, the problem, so certainly the CSS-3s are a different model, right? And this, the integration of health and social services. At the regional health authority level, however, there have been complaints, there has been criticism that in fact the Ministry of Health still retains quite a bit of power in terms of making decisions, and whether or not the regional health authorities themselves are as autonomous as they are on paper. I would say, however, it's a distinct model. It's a distinct model in the fact that it predates most of the other Canadian models, right? So it was there from the get-go, this idea of regionalized structure. But to the extent that it is They have a different kind of power relationship. They have a different kind of way of bringing people onto the board, right? There's a different democratization part of it that may be different than other provinces. I don't know. What exactly? Yes.
Well, thank you very much, Antonia. I just want to say what a pleasure it is to have you here. This is actually the first time in the WRTC's history where we focused on the Quebec health system. It's long overdue. We should have done this I would say years ago, because there isn't a very good understanding here. And I think while it's true that we all live in our own worlds and we don't necessarily understand that well what's going on in other provinces, Quebec has always done a fair amount of experimentation, at least in certain areas. Yes, this is the home of Medicare without a doubt, but there's been so much that's gone on in healthcare since then, and Quebec has been so important in some of those developments that really this is an enormous oversight on our part. So I'm so pleased that you were able to come and join us and put up with that 3 extra hours on that airplane as you got diverted to Calgary yesterday. Yes, you put up with a lot.
I know Regina's down there somewhere.
So thank you very much, and would you please all join me in thanking Antonia for joining us today.